Yeah. So, as you guys know, I'm TikTok Baby Doc, and this is Dr. Michael Narvey, neonatologist, meaning a NICU doc, as some people might know it, at NICU_musings. And we have connected on TikTok through various videos that we've liked of each other's, and then I duetted some of his. But I
Which
actually,
I appreciate.
Yeah, thank you. But I actually wanted to talk to him today about meconium. And the reason for that is, I don't know, a few weeks ago, there was a bunch of misinformation going around about meconium. There was a big user with a large following whose baby suffered from meconium aspiration syndrome. And I saw a lot of information and comments and stitches of their videos that was actually pretty wrong, the information they were sharing. So I was like, why don't I just snag Dr. Narvey and see if we can work this out? So are you down for that?
Sounds like a great idea.
Okay. And then we'll go back through at the end if we have time just to answer some questions. But first things first, Dr. Narvey, what is meconium?
Meconium, I like to, well, first of all, I should say I have great respect for what you do because, of course, I've shared this with you already, but I originally wanted to be an MFM person. So I had a change of heart at the last minute and went into neonatology. So I have a long history of loving obstetrics and gynecology. So
it is a pretty good field. So
it's a great field. But so meconium, I often refer to as a diary of the third trimester. So meconium really is swallowed particles and shed hair and other cells of the digestive tract and bile, which all winds up sitting in the colon waiting for that birth to happen. Ideally, I often say meconium won't make its appearance until after birth because we prefer it that way. But sometimes meconium can appear before birth, and that's what leads to that condition that you were talking about at the beginning, meconium aspiration syndrome, or at least passage of meconium, which can lead to meconium aspiration syndrome. But it's that thick, black, tarry substance that babies excrete, preferably after birth.
Yeah, so just some of the stats there. You know, meconium is going to be first formed in the gastrointestinal tract of the fetus at around 11 to 14 weeks. And then what we want it to do is to pass within the first 24 to 48 hours after birth. But I know that preterm infants, so if we deliver, I hand you a 32-weeker or a 28-weeker, they might have a delayed passage of meconium. Is that true? And if so, when do they typically pass it?
Yeah, no, absolutely. One of the reasons, actually, and this is kind of cool, is, you know, I mean, if you follow me on TikTok, you would know that I'm just always in awe of how nature has created us, right? And one of the things that's quite remarkable is there's a hormone called motilin, which is what drives that peristalsis in the bowel, in the fetus, and prepares that fetus as we know that bowel motility is happening, and I know you would see that, and you look for that dilated bowel sometimes as a sign of problems. But as motilin rises during the third trimester, you start to get prepared for that normal peristalsis, which causes excretion. But with respect to the bowel, and sorry, I actually just forgot what was the original question. Actually, I forgot.
So why don't
they pass it?
The preterm, like a preterm might deliver,
right. So
might pass it like that.
Right. So with the preterm infant not having that same levels of that hormone producing that peristalsis and having that natural tonic contraction of the internal sphincter, it holds that meconium inside awaiting birth. I know we're going to get into reasons why that happens, but so it's not uncommon, and this is something that I think a lot of parents would like to know. And if there are any parents following right now, I think, well, I'm sure there's parents following, but one of the things that parents sometimes worry about is because they do hear that babies are supposed to pass within the first 24 to 48 hours. But when you're a preterm infant, not only do you not have that normal peristalsis, but when you're born and we feed these babies such tiny, tiny volumes of milk, there's not a lot to stimulate the production of that meconium and the passage of that. So it's not uncommon for there to be a delay for that reason.
Right. And then one of the things that we, because the meconium sits, if you think about it, starts at 11 to 14 weeks to develop, and then we wait typically until 24 to 48 hours for the meconium to pass. There is a possibility that as the fetus advances in gestational age, that the meconium could pass before delivery. And that's not
Right.
always pathologic, which means it's not always a bad thing. For example, if we see that in 5% of those fetuses under 37 weeks, they might have meconium stained amniotic fluid. About 25% of fetuses around 40 weeks, which would be the due date, have meconium stained amniotic fluid. And then for those that are post term, and that means greater than 42 weeks, that's 52% can have meconium stained amniotic fluid. So when we talk about going past your due date, especially hitting that 41 to 42 week mark and beyond, that's one of the major things we worry about with post maturity syndrome. And do you want to talk about that a little bit? One of the complications you might have as a NICU doc receiving a 42 plus weeker that may have this post maturity syndrome and may even have the meconium stained amniotic fluid.
Yeah, so that's, I mean, one of the great changes that I think has happened in modern obstetrics is that, at least, and this is one of the things I was a little worried we might get into here, differences between Canada and the U.S., but
Yeah.
there, there's not a lot of tolerance for, I mean, certainly there's tolerance for letting women try to go naturally, and that's what we always want to see. But once you get up to 41.1, 41.2, 41.3, everybody starts getting a little twitchy because we know that those pregnancies are at greater risk of fetal distress. When there's fetal distress, when there's hypoxia, so that's a low blood oxygen in the fetus.
Yeah.
What happens is, I spoke to you before about how the that internal anal sphincter is nice and constricted, but what in the presence of a low oxygen tension in the body, it relaxes, and that meconium can pass. And when the meconium passes, then one of two things happens. In many cases, and you've sort of alluded to this already, in many cases it's not a problem. The meconium passes, the baby comes out a little green, but as long as they're not gasping, they seem to be okay. But if that hypoxia, if that low oxygen continues to stress out the fetus, and it causes them to start to do something called gasping, what can happen is that fluid has meconium in it, and they inhale that meconium. And when they inhale the meconium, that's where we can get into trouble.
Right. So, and this is just isn't for post dates, and we'll get through this a little bit more. But when you think about passing meconium before labor, can it happen just physiologically because the baby is getting past its due date? Yes, it can. But we also have to think about, if that's not the case, why are they passing meconium earlier on? And we may not even know until we deliver them earlier for whatever reason, say the patient's preeclamptic or something else is going on, then we happen to see that there's meconium in the fluid, or they're in labor and they have meconium stained amniotic fluid. So we have to, as obstetricians on my end, I have to think about, number one, what would be the reasons why this fetus is passing meconium? Is it just because they're 38, 39, 40, 41 weeks? Or was there something else going on either before they got to me or during the labor and delivery process? So if I'm seeing someone in labor with meconium stained amniotic fluid, I'm going to continually think about, why is this happening? And does that mean that I have to rush everybody that's in labor with meconium fluid to the OR? Absolutely not. And we'll talk about this a little bit more. But that's something that, the patient should be aware of. We look for, during the labor and delivery process. But again, there's also been many times where I might deliver a baby 28 to 32, 34 weeks for whatever medical reason, say there's severe growth restriction or something else, a chronic abruption or bleeding, and we go to deliver and, the bag of water is not broken around the fetus and we happen to find meconium. So if I'm seeing that, obviously you guys are going to be there for the delivery because it's a preemie delivery. And I see that at 28, 29, 30 weeks, that's also something you guys have to be aware of, right? Because we weren't expecting that. And that's telling me that something was going on during the pregnancy that caused that fetus to pass the meconium at such an early gestational age. So in those situations where we're handing you guys preemie babies and it wasn't necessarily expected because we were delivering them for preeclampsia, is there any special consideration that you have for those preemie babies that have passed meconium in utero?
Yeah, so, I remember, when I was in my training, one of the things that was taught to me was, if you see a real preterm, and when I say real preterm, what I mean is not just a late preterm that's, not, and as I say that, I realize there's going to be someone out there who's had a late preterm in 34, 35 weeks. We had a lot of complications. Sure. I don't mean to minimize that, but what I mean to say is, if a 25-week infant has meconium, and I've seen that once, but if they've got meconium, that is a really, really stressed fetus. And so where that has implications then is how we treat them in the nursery. So we already would feed them very cautiously. Ideally, we want mother's own milk. If we don't have mother's own milk, then we move on to donor breast milk if we have it, or if your unit has it. And we would feed that baby very slowly. We'd probably start with a minimal enteral feeding, which is generally accepted to be 1 milliliter per kilogram, which I know is crazy. It's 1 milliliter per kilogram every 2 hours. So you're talking about, for a 1 kilo baby, you're talking about, 1 milliliter every 2 hours, which is nuts, when you think about how small a volume that is. But that can prevent a condition, which is another thing we can talk about at another time, called necrotizing enterocolitis. But one of the things that becomes a bit of a challenge, and I wanted to get this message out, and probably now is probably as good a time to get it out as any. When you've got meconium, and we've talked about this a number of times already, that's a sign of hypoxia, of a low blood oxygen in the fetus. You may, in your center, already be aware that some babies go through cooling, so they can be cooled for hypoxic ischemic encephalopathy. That's not available, under 35 weeks generally. Generally, most centers now are doing it for 35 weeks and above. So when you ask me, is there anything I would do, for that baby, because we couldn't do cooling, but I would have surveillance looking for evidence of hypoxemia in the brain, especially. I would feed them very slowly. That's a baby that might go on to get an MRI at term equivalent age, looking for evidence of ischemia. So those would be the main things that we would consider.
Yeah. So, you touched on this, we kind of already talked about why they might pass meconium. Those term babies, 37 and beyond, it could just be because they're starting to get close to delivery and they might pass it just physiologically, and it does not mean that they were stressed or anything else like that. And I'll give an example. If I have a 38-weeker that came in, and at some point, or 39 or 40, and they're in labor, and they came in with clear amniotic fluid, because whenever the amniotic fluid ruptures, we always look to see what it looks like. But then over the course of their labor, they may have passed meconium. Now, that doesn't mean I'm going to sound all the bells or anything like that, as long as the tracing, the fetal heart tracing, looks good, because that's also a sign that the baby's compromised. Now, if I have meconium or thick meconium, and again, there's really no table to tell you what's thick, thin. It's kind of a subjective thing, but there's definitely a difference between thin, which would kind of be like green colored water, versus thick, which is kind of like pea soup.
Right.
Plus a bad tracing or a worrisome fetal heart rate tracing, then I'm going to definitely switch gears and be more worried about getting that kid out in a timely fashion. So, you got to look at the whole picture. Patient came in, they had amniotic fluid that was clear, but over the course of labor, it turned to meconium, but the tracing looks great. I'm going to still keep going, and hopefully they'll deliver vaginally. Now, if the meconium's there and then the tracing starts to look more worrisome, or, to a point where I'm like, she's remote from delivery, meaning not close to delivery, plus the meconium, plus the tracing does not look good, I'm probably going to offer cesarean section. But you got to look at the whole picture together. What I'm trying to say is, someone that's at term, that comes in that happens to have amniotic fluid, and things change it over the course of the labor, it doesn't mean we have to rush everybody to a C-section right away. There's other things to consider. So if you're listening to this and someone's telling you in your labor that you have meconium fluid, ask them, does my baby still look okay? Does the heart rate tracing, and you guys are hooked up to the monitor, does that look okay? How long will you let me go? Am I progressing? All those things you can talk about, and we can give you answers for that. There was also a video, and you can give me your 2 cents on this, because I know you're a neonatologist, but I know you like MFM. A lot of people saying that if your water breaks at home and you have meconium in your fluid, you don't have to go to the hospital right away. That doesn't mean your baby's in distress. This is my 2 cents. My 2 cents is, no, it doesn't mean your baby's in distress, but it also doesn't mean that it's not. It could also mean that it is. And really, at that point, you need to be evaluated in some secondary way to make sure the baby's not in distress. So that's why we say, and yes, this is obstetrics, and this is medicine, obstetrics 101. If your bag of water breaks and you have green colored fluid, you need to be evaluated sooner than later, so we can put you on the monitor, assess the fetus, and make sure the kid is okay. I would 100%. Never recommend someone laboring at home, because they're not getting monitored and you don't know. So I don't agree with people on social media that say you can still labor at home, you can still do a home birth, you can still da-da-da. I will never agree with that. What say you, Dr. Narvey?
Well, I mean, this is clearly one of those things where I could lose 1,000 followers depending on what I say,
Yeah.
but it doesn't matter. It doesn't matter.
No.
No. So the way I always look at this is, um, so first of all, for low risk pregnancies, if you'd like to deliver at home, I know that much of the world does that. I know that much of the world does not use obstetricians. They, use midwives, and it's home births. And so I don't want to come across as saying all babies need to be delivered in the hospital. That's not the case.
Right.
What I do sometimes say to people, though, and I'm reminded of that by your question, is you have to really look at yourself and the type of person you are. Because in a situation like that, the way I would approach is I would say, is it a guaranteed problem to deliver at home and that the child will be born hypoxic and need extensive resuscitation? No, it's not. But equally, as you said, it has to do with that sensitivity and specificity. Is it a guarantee that they're not going to have any problems? No, it's not, nor is it a guarantee that they will. So you have to ask yourself what kind of person you are. The safest thing in that situation I would recommend is to come into the hospital, be assessed, and there's no reason, at least here in Canada, the midwife can come, they can help deliver, they can do the delivery in the hospital, but come and get assessed, because if you're going to stay at home, I would ask yourself, who are you staying at home for? Is it for the baby? And I would make the argument that the baby is actually oblivious. The baby doesn't know whether, if you want to have a water birth in the hospital at that point. The baby doesn't know where they are. This is for your experience. But if you're the type of person that if you're wrong and that baby comes out very, it's never going to forgive yourself. And if that's the type of person you are, then I would say, please go in and get assessed. I would ultimately say go in and get assessed regardless. But that would be my position.
Yeah, and I know yours was a much more eloquent explanation than mine. Listen, I'm a high risk obstetrician, and I see a lot of good, but I also see some of the not so good. And I've seen the consequences of not coming in with meconium. And so obviously I'm going to be recommending anyone that has it to come in, because I don't want that to happen. But just like Dr. Narvey said, you got to kind of decide where you're at. Are you, do you want to stay home and you understand the potential consequences? That's your right to do so. Absolutely. But if you stay home and then something happens adversely because of the meconium that wasn't addressed in a timely fashion, how are you going to feel in that situation? So we have to know both sides of it, and you have to decide as the individual and make the best decision with your, you have autonomy to make that decision. What is going to be best for you and your baby? Is that kind of, I don't want to come across too harsh, but also I don't want people to dismiss it either. Does that make sense?
I mean, I think we're very like-minded on this. Yeah, no, you know what? I'm reminded, actually, a little off topic, but similar. I had friends when I was in Alberta. I used to live out in Alberta, and friends were so desperate to have a birth in their community, and they had a placenta previa, and of course, they asked me, what do you think should happen? I said, I would relocate to the tertiary hospital, because if you start to bleed, there's going to be a problem. And sure enough, they stayed, they ran into problems in an ambulance, emergency section, baby in the NICU. So, that's where I sort of look at it like, who are you doing it for at that point? It's, if you want what's best for the baby, deliver them in the best place possible. And the last thing I'll say about this is, because this is an actual analogy I give to parents sometimes. I'll say to families, have you ever gone gambling? And that, most people say, yeah. And I say, okay, let's say you went to Las Vegas, and when you walked in, you were at the blackjack tables, and you're looking at which table you should go to. And the pit boss looks at you and whispers in your ear, hey, that's the hot table over there. That's where I would go. Why would you go anywhere else? If the odds are actually even incrementally better, when it comes to your money, you would never go anywhere else. So why, when it comes to the baby, if the odds are just incrementally better by getting assessed, why wouldn't you go? That's sort of my that's my thoughts on that.
Yeah, and I agree. And we'll jump on to the next topic, but you're hearing it from an MFM and the NICU doc, and we're trying to educate without causing fear. And sometimes it's hard to do because you guys don't always want to think about these things, but it's something to be aware of. Meconium, there's a saying that's in obstetric, shit happens is a common phrase. We also say meconium happens. That's kind of something that we always say, and it happens. And being prepared and knowing how to address that if you're at home, or what questions to ask if you're in labor and it happens, or if your baby is affected by meconium aspiration, what questions to ask someone like Dr. Narvey is what we're trying to do here. But I wanted to touch briefly on we talked about meconium happening just because. We also talked about meconium happening because something is happening either during the pregnancy or actually during the labor process that has stressed the fetus out, where there's either acute, what we call hypoxia, which means an acute drop in oxygen saturations, or a chronic hypoxia, which means that throughout the course of the pregnancy or throughout the course of a period of time that the baby has had episodes of hypoxia that has led to a chronic state of hypoxia. And some of those things that you might think of, a placental insufficiency. Why might that happen? The placenta is a bed full of small vessels, and sometimes there are conditions that affect the function of those vessels, like preeclampsia is a great example. A chronic abruption is another great example. Preeclampsia is also a risk factor for meconium stained amniotic fluid. Any kind of infection, a viral infection, can also cause that. Certain exposure to drugs like cocaine is notorious for causing meconium passage in utero before, either before labor or during. If someone had no issues in the pregnancy, but their labor's prolonged for whatever reason, that could also cause meconium to pass. Growth restriction on the fetus is another reason, which I'm sure you've seen that happen with some of the growth restricted babies you have. And then another one that I've talked a lot about here is cholestasis of pregnancy. That's one of the reasons with cholestasis of pregnancy, we recommend delivery earlier than going to your due date, is for this very reason here, the increased risk of passing meconium and adverse things happening. So that list there, I'm sure you've seen all of these babies that have been, had these risk factors that are conditions that have caused meconium stained amniotic fluid. And then I want to talk about meconium, how you treat meconium aspiration syndrome in a fetus. But one of the other things that came up on this app was that someone said for this particular user who was in labor, and she was told the baby had meconium aspiration because the baby inhaled the poop or meconium during labor. And this person said that's absolutely not true. Babies don't do that. Well, that's not true. It can happen during labor, just like Dr. Narvey said. With or without amniotic fluid, even after rupturing their fluid, rupturing their waters, they can still inhale that fluid that's during the labor course. So that can happen, and that's something that we need to watch for during the labor process. And again, look at the tracing and all those things. But again, there's so many things to look at. But I'm not going to go through all that because it's way beyond the scope of this topic here. But if you're in labor and your bag of water breaks, and at any point in time during your labor they tell you have meconium stained amniotic fluid, you have the right to ask questions. You have the right to ask, how is this going to change the management of my labor, or will it change the management of my labor? How is my baby looking on the tracing? All of those things you can ask to get an assessment of where you stand. And again, there's so many things to look at. I'm not saying here at all that everybody has meconium stained amniotic fluid has to be rushed for a C-section. That's the wrong thing to do. Many of people can still deliver vaginally and everything's just fine. But there are other things we can look at, meaning how you're progressing in labor, how the fetal heart tracing looks like, for us to kind of get a gauge on how long we need, what's the longest we would go for you to have the vaginal delivery. But the other thing that's important is to have, if there is meconium fluid, we usually let the nursery know, the NICU know, hey, this patient in room 9 has thick meconium. They're getting ready to deliver vaginally. Now, I want you to talk about what is the suctioning policy. Now, I know things changed around 2015, whether to suction or not suction.
Right.
For those, so that means I deliver the baby, Dr. Narvey. Do you want me to suction the baby that has meconium stained amniotic fluid or not? And why? Give me the reason for your answer.
Now, are you talking about as the head's being delivered, or are you talking about?
I personally don't leave the head there and then suction. I get the baby out because I don't like sitting the head there. But and it's harder for the patient to wait to push anyway. So yes.
Yeah. So I'm going to say I've been around long enough, and I can't believe I'm even saying this, but I've been around since the late 90s, in neonatology. So I've seen it all. I remember suctioning everything that moved. I remember. Then we went and we entered. There was a phase where like you were saying you don't like to do, and you shouldn't do it. We used to say to the women, and believe me, as a man, I felt awful when I was in obstetrics, and this woman has delivered the head. She's desperate to get these shoulders out, and suddenly you're saying, straight, don't push, don't push, don't push. Yeah. I have to suction. Well, that turned out it didn't help, right?
Yeah.
And the reason it doesn't help is because if you actually have a baby who's inhaled meconium, it's already happened. And so suctioning out the mouth isn't going to help, because they're not going to inhale it, which is what we thought. They're not going to inhale it when they take that first breath and inhale that meconium. No, it's happened because of the gasping. So no, we don't need to do that. Now, I'm so happy we're talking about this topic, and I hope, I can't help but tell you, I've been a bit distracted as I've seen lots of compliments come through, and that's wonderful. Happy to hear people are really enjoying this. But one of the things that was so important to get across in this session is that in the 7th edition of the neonatal resuscitation program, and now the 8th is coming out, but in the 7th, what they said was, hey, no more routine suctioning of meconium. And I want to put, about 5 underlines under the word routine. So what we used to do is, if the baby came out and they weren't crying, they had poor tone, they weren't moving, what we would do is we would say, that's a flat baby, and we would put the endotracheal tube in, a breathing tube in, suction the meconium out, put it in again, suction more meconium out. And the reality was, we thought we were doing the right thing. And there was some evidence, that was the right thing for the non-vigorous patient. But then some other evidence started building, saying that actually probably doesn't help. And the reason it doesn't help is because for the average, and this is an important point, the average neonatal care provider doesn't intubate a lot. And so what happens is, you're desperately trying to get this tube in. While you're doing that, their lungs are collapsing. You're not getting the meconium out. And so the kids who aren't getting adequately ventilated actually can get even sicker. And so what ultimately happened was, there was a recognition that, hey, maybe we should be trying to establish something called FRC. I don't want to get too technical, but FRC is functional residual capacity, meaning put a bag and mask on the baby, start to breathe for them, get the lungs inflated, because you're probably, the average practitioner is better to just get the lungs inflated, get some air moving in there, start to get that PO2 rising, that the pressure of oxygen rising, and help prevent something that can later happen called pulmonary hypertension. So that was the recommendation. The reason I said underlined routine 5 times is because if those initial steps aren't working and you can't move the chest, and you're trying to bag them and the chest isn't moving, the oxygen isn't rising, you would then intubate, right? You would then put the tube in, and then you would suction. We just wouldn't do it at the outset. So the last thing that I'll tell you, and I mean, I could talk for an hour myself about meconium aspiration, but it's a really interesting, tragic, it can be tragic, of course, but it's an interesting condition because of a couple things. It's interesting because it's not just, sorry, that was really cool. I don't know how anyone.
I don't know.
Did you see that? That just showed.
Yeah, I did. Yeah.
The heart. That was
Yeah,
really cool.
I don't know.
I've never seen that before. So whoever did that, thank you very much. But Meconium aspiration syndrome, people think of it just as a pneumonia, but it's not, because there's really 4 components to it. So one component is, you've got obstruction. So you get these chunks of meconium going into these tiny little airways of the baby. Some parts of the airways collapse. We call that atelectasis. And other areas actually get very dilated, because air gets past the blockage when they take a big breath in, and then when they breathe out, the airways collapse a little, and we call that a ball valve mechanism. And so you can get this expansion of some areas, which we call hyperinflation, and other areas are collapsed. The areas that are hyperinflated can actually blow a hole. We call that a pneumothorax. That can lead, either of those things can lead to the low oxygen, which then prevents the blood vessels, which should be relaxing to allow blood flow to get to the lung, from relaxing, and then you get pulmonary hypertension. The last thing you can get is inflammation, which can cause all sorts of problems. Years ago, like when we were training, I think we trained around the same time, years ago, there were trials of steroids to try to deal with the inflammation. That went away. And the reason it went away, two things actually happened. It was one thing that killed both strategies. We used to use ECMO a lot. So
For Meconium,
life support, heart-lung bypass, for those that don't know. We used to use that all the time, or a lot for this condition. And we used to use the steroids. But then two things happened, and they're really important. One was, it was recognized that surfactant, talking about preterms, surfactant, which we used to use, well, not just, we used to use exclusively for preterm infants, it turns out it's a treatment for Meconium aspiration syndrome. It helps. It helps with the Meconium aspiration syndrome. And the other thing that happened, and I'm old enough, and I'm sure I know you are as well, to remember, I was in Med 1, and I was told, scientists have discovered endothelial relaxation factor, right? And then the next year they said, it's nitric oxide. So, nitric oxide, surfactant have really changed the landscape.
Changed things, yeah.
I'm in a, last thing I'll say is, I work in a center without ECMO, without a heart-lung bypass program. I can't remember ever sending a child in my training or in my career for ECMO now, because of surfactant, because of nitric oxide, modern ventilation. Anyway, that's the truth.
Most of the time now, it's for heart babies. ECMO is used more commonly now for heart babies with complex congenital heart disease. But I agree with you. Back when I was training, and even early in my career, we did the ECMO a lot for Meconium aspiration syndrome babies. But yeah, it doesn't have I seen it recently? I've actually seen it recently, but it was a really bad case. But again, it's not needed as much anymore because of the newer therapies that we have. But yeah, we had the capability of doing ECMO, but again, it's not used nearly as much as it used to be, thankfully, because we do have better treatments. So one other thing I wanted to touch on about in labor with meconium fluid is, for people who are listening, there's something called an amnio infusion, meaning that after the water is broken, sometimes if the fetal heart tracing is having decelerations, or it used to be that if there's meconium stained fluid, especially the thicker meconium fluid, you could give an amnio infusion. That means a little catheter goes back up into the uterus, and we put fluid, a sterile fluid, into the amniotic, into the uterus, to help not only give more fluid around the baby, but also to kind of dilute that amniotic fluid. Earlier in my career, we used to do that a lot. It was kind of, I wouldn't say it was standard, but it was more routine, if you would, to do an amnio infusion if babies have meconium stained amniotic fluid. But the studies since then have shown that it doesn't change anything. So that's, we don't do that nearly as much, unless there's other factors at play that an amnio infusion might help. But that's not something that's going to help with the meconium situation during the course of labor. The best thing for labor is having the baby on the monitor so we can see the fetal heart tracing. The fetal heart tracing means where we trace the baby's heart rate as well as the uterine activity. It's not perfect. It's not 100%. However, it can help us determine what the oxygenation status is. And that's by looking at the variability of the actual tracing. Once that variability starts to decline or even become minimal or absent, then you have a compromised fetus. And that means we need to expedite delivery. If they're close to delivering, then we need to, or they're pushing, we can use an assisted delivery. If they're not close to delivery, then we might recommend a C-section. So for, those, you have to put everything together when you have meconium fluid during labor and delivery. And it's not something to be scared of, but I do think it's something to ask questions about. And I do think patients should ask questions. If you're told that the baby had a bowel movement, one of the common things people say is, oh, the baby had a bowel movement. And that's called meconium. That's what the nursing staff or whoever is saying. So you have the right to ask questions and get some more information about that during the course of your labor. So you talked a lot about the meconium aspiration syndrome and what we do. I know it's something that's scary because there was a lot going on about it during on social media about it, and some bad information. So if you have a family that's otherwise healthy baby, did not, had no problems in the pregnancy, none of these other things that we talked about that are risk factors for passing meconium, how do you talk to them as the NICU doc managing their baby to help get them through this? Because it is traumatic. Anytime it's your baby, that, I had 2 babies in the NICU for 6 weeks, and it wasn't from meconium, they were preemies, but, and I'm a physician, and I was still traumatized to some degree for those 6 weeks. But what are some of the, things that you think patients might want to ask, or some things that if other providers are listening that they might want to talk to patients about? Like, how do you approach that situation?
Boy, I mean, there's a lot of stuff there
Yeah.
to unpack in terms of thinking about how you would do that. I mean,
Yeah.
one of the things that I tell any family going through the NICU or the NICU is that, try not to, be a slave to the monitor. It's very difficult. You've got the monitor, it's beeping, it's alarming, and you're looking at it. But you need to try to look at things either every couple of days, every 3 days,
Yes.
and try to ask yourself on this journey, and it's a journey, try to ask yourself 3 days after, admission, are things worse? Are things better? Is there anything I can hold on to that's a little bit better? Maybe the lungs aren't as good, but maybe the heart's better. Maybe the blood pressure's better. Like, is there anything you can hold on to that maybe is a little bit better? The other thing that has really become in vogue, and I don't think it was probably in vogue as much when your twins were there, is in a condition like this, we would, or any respiratory condition for that matter, whatever monitor you have in the unit, virtually all of them now, in fact, I think all of them, can produce something called a histogram, an oxygen saturation histogram. And it is so wonderful. So what does that mean? What is an oxygen saturation histogram? So we can get a report, and we do get a report on every single baby every day who's receiving respiratory support. What was their oxygen level in the last 24 hours? What percentage of the time was it 95 and above? What percentage was it 91 to 94?
Yeah, no, I didn't have
86 to 90.
that.
Right.
When I had the twins, yeah.
And so it gives you something objective to hold on to. So, if the histogram is getting better, if it's shifting upward,
yeah,
then even if it doesn't seem like things are actually getting better, you can actually say objectively, yes, it is, right? So that's one thing. The other thing is, sorry, somebody asked blood gas or SpO2. It's an SpO2.
Yeah.
Don't be afraid to ask to speak to the neonatologist. I think parents, it's natural. You think the worst. You're fearful. You're terrified. Sometimes you don't even know what to ask, right? So we are there. We have doctors there all around the clock. Nurses are fantastic, and I can't say enough about nurses. I married one, but nurses are amazing. But sometimes they want to talk to the doctor, and so never feel like you have to apologize for disturbing the doctor. That's what we're there for. So I think like I said, use the oxygen histogram, speak to the physician, speak to your nurses. And another thing that's really important, and somebody would shoot me if they were listening to this if I didn't bring it up, the concept of family-centered care. Ideally, the family should be at the center of the care team. Yeah. So be there for rounds. Be there for rounds, contribute, ask your questions, say your fears. And I mean, one of the interesting things, not about meconium, but one of the things that I commonly ask about when we have a baby with, let's say, hypoglycemia, so low blood glucose. So many families think this means their child is going to develop diabetes.
Yeah. And
what I tell them is, I'll say, are you worried that this might be diabetes? And they say, yeah. And I say, no, that's the exact opposite problem. This baby has too much insulin. Your baby does, diabetes is not enough insulin. So I think those are the things, is communicate and be part of the team. You'd be surprised if you're just there for rounds, the stuff you can learn. So I mean, that's what I would recommend.
Yeah, and I think when you're in the NICU, and listen, I was a almost full professor by the time my twins were born, and it's intimidating. You have all of these babies, and we didn't have individual rooms back then. Now they're a lot of NICUs are transitioning that, but all the monitors, all the lines, all the beeping, all the noises, all the other babies in the NICU, it can be intimidating and overwhelming. It can be. And then you also have babies that are compromised, or mine were small, and it was scary for me. But what we want you to know from the doctor's end of it is, don't be intimidated. Ask your questions, express your concerns, No question is too small and no question is dumb. Any question you have is important, especially when it comes to the health of your child. So, and I'm sure Dr. Narvey feels the same way.
Yeah.
We want to break down those barriers between the physician and patients, so that they are more empowered to ask questions and get their concerns addressed. And that goes without saying when you have a baby in the NICU. Myself, even as a professional or as an MFM, I kind of let go, and I did not wear my doctor hat in the NICU because I knew I would drive myself nuts if I tried to do that. I was truly a patient, the parent of 2 patients in the NICU, and that worked better for me, because I let them do their job, and I still ask questions because I'm not a neonatologist.
Right.
I wasn't going to pretend that I was. That's not my area of expertise. So please ask your questions and get your questions answered. It's 8:18 your time. How much more time do you have? Do you want to answer some questions, or?
Yeah, we can answer a few questions.
Yeah. Okay. So one question that came through was, is there any way to know before breaking the bag of water if there's meconium stained amniotic fluid there? The answer is no. Even with the thick meconium fluid, because vernix, which is that creamy stuff on the baby's skin, if you look at the amniotic fluid, you could see it very sometimes you can see it particulate, or it looks like a snowstorm in there, but that is usually vernix, and you can't tell the difference between it being vernix or meconium if it's really particulate type meconium. So no, there's no way to know. I will tell you one story though about a patient. It wasn't my patient. Came in for a routine induction, 40 weeks. It was a private doc who was delivering on the labor and delivery unit, and I'm there 24/7. The doc wasn't there because it was an induction, and a lot of private docs stay, are at home for a certain part of the induction. But the tracing, when they came in, because I'm constantly scouring tracings, and I was like,
Right.
it's tracing. But the water wasn't broken. No problems at all in the pregnancy. Routine first. And I just did not like any. I said, okay, we'll give him maybe some fluids, and I'm sure it'll perk up. Still didn't perk up. And I just called it. I said, I don't like this tracing. She's barely a centimeter, but I don't have a good feeling. And sure enough, well, it wasn't my patient. I just gave my 2 cents. They talked to the patient, and the tracing never really improved. They went back, and the baby had thick neck. And how would we have known that if we hadn't had the baby on the monitor? So that was a near miss. The baby ended up doing okay. It did have meconium aspiration, but not severe.
Right.
But we would not have known that if they weren't on the monitor. And the patient had no idea. So, and again, that's not to scare everybody, but there's a lot of things we don't have control of. We can't prepare and prevent everything. Unfortunately, I wish we could, right?
Oh yeah.
Yeah.
No, the number of times that I've thought you use that retrospectoscope, wish I had done that, but you can't.
Yeah, I wish I could prevent everything. Sometimes I feel like I can, but not always. What's this? Can we talk about how medical monitors in hospital are only the ones that are proven accurate in babies? Maybe they're talking about like these home monitors versus what's in the hospital.
I think they're talking about that. Yeah, so that can be a dangerous thing to get into. But what's interesting is a difference. So this is a big difference between the U.S. and Canada. I've learned it is far more common in the U.S. to send babies home from the NICU who have a history of apnea prematurity with a home monitor or recommendations for home monitors. We don't do that. I won't get into why, but I suspect it has a little bit to do with our societies.
So you're saying you don't do that?
No, I've never sent a baby home. We keep them, once we believe that they're free of apnea prematurity, then we just send them home after a period of observation for 72 hours without any apnea or bradycardic events. The problem with those monitors, and I think that the CHIME study, CHIME, from around 2000 revealed the problem. The problem was because everybody thought that there's a bit of a misconception that people often think apnea prematurity is the same as SIDS. It's not. Apnea prematurity typically is over and done with at the latest by about 44, 45 weeks post-menstrual age. SIDS peak is around 52 weeks, so there is a gap between the two. So the CHIME study showed that you couldn't actually prevent SIDS. You couldn't pick it up by sending kids home on home monitors. what they did find was a number of interesting things. Number one was that these, what they call transient episodes of bradycardia, or TEBs, and I'm sure you probably experienced these
Mm-hmm.
with your twins.
Mm-hmm.
They could last at home on a home monitor for a month.
Mm-hmm.
And so if you were like 1 a day, 2 a day, and so if you're going to keep them in the hospital for these TEBs, you'd be there forever. So the home monitors aren't great. There is one that I'm aware of that's out there. And I don't even know if are we allowed to give names.
Yeah,
I
I
don't
mean,
want
if
to
you, I mean,
advertise.
we're not getting paid for anything here, so if it's, I
No.
mean, we're
So
not name dropping for any. Yeah.
there is a study I've seen on one. I believe it's called the Owlet.
Yep.
And the Owlet has been compared to what I consider to be one of the best products out there by Masimo Technology.
Yeah.
Medtronic has their own technologies for monitors.
But they're also going through an upgrade too. I think Owlet is also. Yeah.
Yeah, the Masimo and the Owlet have been compared, and they seem to be equivalent, or very, very close to being equivalent. So if you Owlet was just told to stop being sold. Well, I'm
Oh
not.
yeah,
I wasn't
that's
sure
right.
about that.
So wait, why was it? Oh no, not for anything bad. They is it the FDA wants them to get go through the I think it's the investigational device licensing or approval, not because the monitor was bad. They just wanted it. When you're doing studies or doing a new product, that's what they're wanting them to do. Yeah.
Okay, well that's good for me to know. I mean, we don't use it here.
Yeah.
I mean, it's sold here. You can get it. If somebody says to me they really, really have wanted to have a monitor at home, that's the only one that I've ever mentioned, because I did see that comparative study. But in general, we don't send them home with monitors.
Yeah, there's a lot of questions here on cholestasis, and I get this a lot. The recommendations, we have some updated guidelines, and I've actually went through this. And if you go to my Instagram, I have several posts. If you go under my pregnancy highlights, but the recommendation is to deliver by 37 weeks. There are new recommendations if the bile acids are greater than 100 to deliver around 34 weeks. As far as antenatal testing and all of that, we have guidelines for that are updated as well. But it's also very important to make sure that you have an accurate diagnosis of cholestasis. I see a lot of fudging of the numbers and fudging of the diagnoses and diagnosing it way early in pregnancy when cholestasis isn't there. You got to make sure that the diagnosis is accurate, because what you don't want to do is be incorrectly diagnosed and end up with a preemie baby. And even at 37 weeks, if there's not a true diagnosis of cholestasis there and there's something else going on and you deliver that baby, the baby could still have issues. So we want to make sure for cholestasis that we appropriately diagnose it. I hear all the time, I'm 18 weeks, 20 weeks, I was just diagnosed with cholestasis. That is not going to be cholestasis, okay? What I found is that any kind of time you get a diagnosis or elevated bile acids or abnormal liver function tests, there's usually something else going on if it happens that early in pregnancy. So my only thing would be make sure you have an accurate diagnosis. If you have the ability to see a maternal fetal medicine specialist as a consultant, I would recommend doing that so that your pregnancy is managed appropriately. So that's my 2 cents on cholestasis. I'm trying to think if there's anything else. Did you see any other comments come through while you were looking that we should address?
No, I didn't see. No, I mean, I saw a lot of comments, but certainly nothing that was in my wheelhouse.
Yeah.
I saw the cholestasis stuff. Likelihood of neck with caffeine citrate. I've not seen that, actually. I've not seen. I've certainly seen with intrauterine growth restriction, there's a risk of necrotizing enterocolitis. And that's related to, again, we could talk about that as a separate event, but that has to do with bowel ischemia in utero. But yeah, no, that could certainly be another discussion.
And we'll close with this. The whole thing about being present for rounds. I think, and I wish that was ideal for every NICU setting, but I'm going to stick up for the NICU, some NICUs across this country, and say it's not ideal for every NICU setting. And here's the reason why. When my twins were in the NICU, we did not have individual rooms. So there was incubators next to incubators. And I could just imagine if there was families at each incubator and a team going through, it would be too many people. This is pre-COVID in that area at the right time. So they did not allow us to be present for rounds. It did not bother me because I made sure my questions were answered once I was able to go there. Now, with the different settings in our new NICU, it now has individual rooms for the neonates. It's easier because you're in there with your own baby, not around everybody else, and the doctors come into the rooms and round. That's a different scenario. So not all NICUs are set up that way. So just be mindful of that. And if they're telling you that they don't allow parents there for rounds, just ask them why. And I'm sure they have a perfectly good explanation, but I don't want to throw any NICUs under the bus because I know back when mine were there, it would have been a nightmare to have all parents there for rounds. So I did not blame them for that.
No,
would you agree with that?
100%. I mean, we work, where I work here in Canada, there's 2 level 3 units. One of them has individual patient rooms and the other one doesn't. Mm-hmm. And you're a spot on. I mean, you can't have all the parents there in this cramped area. There's mm-hmm. a whole bunch of reasons for that. I mean, one is privacy, one is infection control precautions.
Yes. Mm-hmm.
So I mean, that's unit design is a whole other topic. But what I would say is, and you hit the nail on the head, it's all about communication. It's all about finding out what the standards are in the unit. And I would probably end with this comment, and I know this sounds like it's a bit cheesy, but I believe it. I think I made a post about this once mm-hmm. where I said there's no such thing as difficult parents.
Yeah.
And I really mean that.
Mm-hmm.
Sure, there are parents who sometimes lose their temper, but why are they losing their temper? Well, they're losing it because they care. They care about their baby. Or babies. They want mm-hmm. to advocate. They're scared. They may have misconceptions about what's going on. Mm-hmm. And rather than just label them as the difficult parent, is it not our job as the physicians to figure out what is going on here?
I'll talk about that too, but about the pregnant individual. Stop labeling pregnant individuals as difficult. Find out what it is that's making them react a certain way. There's usually something going on. Yeah.
Where is the communication breakdown happen?
Yeah. And then one other thing, we got 1 minute left. Nicu Consults. I love my NICU. I really do. We have a great working relationship. If you are hospitalized for any complication preterm, or you might be delivering preterm, ask to talk to the NICU, because they could come and talk to you about, hey, talk with the OB-GYNs. This is what's going on in your pregnancy. Are we thinking you're going to deliver early? I might be 32 weeks. What are the potential complications or things I have to look for if my baby's a 32 weeker in the NICU? If you're at a hospital and you're at increased risk for delivering early and they don't have a NICU, ask, will I need a NICU? Because a lot of patients will have to be transferred. We get tons of transfers in because our NICU can handle the certain gestational ages. So don't be upset if a hospital wants to transfer you early to a place that has NICU capabilities, and because they're worried that you might be delivering early and they want you to get the best care. So do you guys get a lot of transfers of early preemie babies?
Well, I mean, we do. We do get about, for out of hospital births, we see about 350 to 400 a year. Which you have to understand it you might actually say, based on where you are, gee, that sounds little. But I mean, we're talking about a population of 1.4 million. As opposed to populations in the tens of millions.
And there's always that conversation too. Is it better to deliver the baby and transfer the baby, or transfer the baby inside the mom? So that always is a conversation that needs to be had too. If you're at a hospital that doesn't have NICU capabilities, most of the time they try to transfer the pregnant patient and deliver the baby there with the NICU capabilities versus delivering the patient and then transferring the baby, because then patient and baby will be separated. So those are all things to talk about. And I know it's a scary thing, but the more you ask, the more you'll be empowered and the more information you'll have to help you get through this. So
yeah, absolutely.
Yeah. Thank you, Dr. Narvey. This is awesome. We'll have to do something else.
Thank you.
If you guys want us to talk about anything else, just let me know. Send us a comment on one of our videos or something. Let us know what you want us to talk about next.
Yeah. It's been awesome.
Have a good evening. Thank you so much.
Okay. Take care.
Bye-bye.
Bye, everyone.